Yet the U.S. has one of the highest childhood obesity rates in the world, and because of that, health officials are predicting that this generation of children may be the first to have a shorter life expectancy than their parents.
You're going to have to speak up. Those are only for recording. You project for.
Okay.
Thank you.
For children between ages 2 and 5, the prevalence of obesity increased from 5% to 12% between 1980 and the early 2000s, according to government figures. For older kids in their teens, the jump was even greater, with more than a tripling of adolescents well over their recommended BMI in the same time period. All of their health indicators are pointing in the wrong direction, toward diabetes, hypertension, heart and liver disease. We also, so I'd like to open the discussion today by addressing that contradiction. What's behind this huge gap in the health of our children, and what can we do to close it? We're fortunate today to have with us two panelists who I think will provide some interesting perspectives on those questions. To my right is Jay Skyler, Associate Director for Academic Programs at the Diabetes Research Institute at the University of Miami, and Jay has studied diabetes for 3.5 decades. To his right is Mike Barber, Chief Technology Officer at GE Healthcare, and has a degree in electrical engineering. Mike is also Vice President of Health Imagination. As you heard last night, GE's new program aimed at reducing cost and improving access to health care. And as we also learned, Mike has, what is it, $3 billion to play with to make that happen. So we're expecting big things. So Jay, let's start with you. Why do we have kids developing diabetes and heart disease, and why do we have one of the highest infant mortality rates in the world when we also have some of the best technology that medicine can provide?
Well, let me start with the issue of heart disease, diabetes in children. I ran a diabetes summer camp for 15 years from 1970 to 1985. And all the children that we saw there, save a single child, one summer, were children who had what we call type 1 or juvenile diabetes, which comes about because the body's immune system destroys the insulin-producing cells in the pancreas. And basically, throughout the time until the mid-1990s, that was the only type of diabetes that we saw in children, and they're basically thin children. Since then, there has been an epidemic since the mid-1990s of obesity-induced what we call type 2 diabetes, what we used to call adult diabetes, occurring in adolescents, particularly adolescents in non-Caucasian groups, which have a greater frequency of obesity, highest being in American Indians, but also in Mexican, American Latinos, and in African Americans. And it's just been absolutely astounding that if you go into a pediatric diabetes clinic in most urban areas today, you find that 40% of the people have the obesity-related type 2 diabetes, whereas up through the 70s and 80s, you never saw any of them. I have in 15 years at camp, they need to, but I think they're sitting in front of televisions and computers and other things much too much, not getting enough activity. We're not eating right. We can talk about eating issues in a bit, but all of this has led to what obesity induces is something called resistance to insulin, or insulin resistance syndrome. Insulin resistance, if you are genetically susceptible, unmasks type 2 diabetes, unmasks the risk of liver disease, increases cancer risk, increases Alzheimer's risk. It is a major factor underlying so many of the diseases that affect society today, and the obesity brings that about, and then the disease, if you're genetically at risk, becomes unmasked.
I'm just going to ask you briefly to explain that resistance. How does that happen, and what does that have to do with obesity?
What obesity does is change the metabolism of cells in such a way that insulin does not propagate its signal appropriately to cause nutrients to be metabolized. And so that cellular resistance is present. It's present in everybody who's overweight and obese, but only those people who also have a genetic defect that can't compensate for it end up with diseases. So if your genetic background is to, let's say Mike's develops insulin resistance and his family history is of hypertension, he will end up having hypertension at a much lower age and end up with a blood pressure elevation, because one of insulin's actions, which now you're resistant to, is to cause dilatation of the blood vessels and lowering of the blood pressure. And if you're resistant to the action, you're going to unmask the hypertension. By the same token, if you have the genetic susceptibility to diabetes, let's say I have that, actually I do, what happens then is if I become insulin resistant, my insulin doesn't work as well to control glucose, and therefore diabetes becomes unmasked. And so if you take everybody who's significantly overweight and obese, only about 20 or 25% of them will develop diabetes, but they all have insulin resistance. Another group, partly overlapping, will develop hypertension. Others will develop lipid abnormalities. All of those things collectively add up to an increased risk of atherosclerosis and heart attacks. And there's also the relationships with several other diseases, non-alcoholic liver disease and Alzheimer's disease and some cancer risks. And so it becomes a major problem. If we could control what people's weight were and get them more physically active and keep them thin, we would solve many of these disease problems that we're facing as a society today.
I want to come back to that, but Mike, I wanted to hear from you as the provider of some of the latest and greatest medical gadgets that medicine has today. That we can now probe the body in ways that we've never done before. Is this technology misdirected in a way? Can we redirect it toward some of these things that Jay is talking about?
Most of the technology people encounter it once they already have a disease. So it's focused around helping to diagnose, detect. There's very little actually from a technology perspective in prevention. So clearly there is some redirection that's possible. Really understanding, as Dr. Skyler talked about, insulin in the body, as you consume sugars, it spikes, it goes up, it goes down. You really want to have it regulated because it is a metabolic activity which monitors a number of different things or influences a number of different things. And so having some type of, so if we're talking about our children and the next generation from a technology perspective, it's what things can be built in from a biofeedback perspective to give them information of what they're doing to themselves. Because oftentimes you don't really realize when you drink that fully sugared soda what's happening to the insulin buildup in your body and is it breaking down the glucose? Is it doing what it was intended to do? And so right now the technology, wonderful technology that we have is really around finding disease, doing disease management, but it's very little at this point in the areas of prevention. And most of that is lifestyle related. So how is it that you can help individuals monitor themselves and make good choices? Because that's really what we're talking about, is good choices for exercise, good choices for eating, and how can you redirect technology to get into that space?
How can we? I'd like to hear some of the things that you're looking at. For example, helping people who are at risk, right? That would be the issue, because people who are already diagnosed are aware of their condition. But I think what we're talking about here are children who are at risk and trying to prevent them from going along that path toward disease.
And yes, and there's there's studies that have been done. There's a 7 to 10 year sort of buildup that if you can in fact find out. And so there's some research that's going on to see if through various tests, and as technology gets smaller and smaller, so you can start wearing devices on your body that can monitor blood pressure, that can monitor your heart rate, can monitor different functions that are going on in the body. Is that a way to then be able to do that? Right now there is no, when you're down at the cellular level, doing that in real time is something that's very difficult to do. So I think the first phase will be, is there some type of test, whether it be through fluids, saliva, or other mechanisms that people will have to be able to do to determine what's going on inside their body. The issue with that is how many times will you do that? And so when you can make it ubiquitous, I think that's really when we'll get to that space where it can really make a difference in kids. Because a kid who's 5 or 6 or 7 years old is not going to go and take some type of test which requires even a pinprick like you do after you have diabetes. If you do that earlier, you can, again, understand this insulin level and buildup. But children aren't going to be able to do that. So can you make it easier for them so it's actually ubiquitous and they don't realize that it's happening? And that's what we're focusing on and trying to do research around, but we're still years away from that.
And I think, that's probably the right direction to go, because there's some studies showing that even with the early electronic medical records impact so far, that people who are able to see, for example, if they are hypertensive and they're able to see their readings over the course of a day or several weeks and can see when their levels spike, if they ate certain things or did certain things, that visual reference seems to be very powerful. So what you're talking about here is doing what seems to be, from a technology standpoint, a bit of low-hanging fruit. I mean, it must be easier to develop a monitor like that than it is to develop a scanner, an MR,
but
the next generation MR.
Oftentimes you need, it's a matter of how do you make something, again, so it's non-intrusive to the person for their everyday activity. So if I build something that's a big, heavy vest that somebody has to wear, they're not going to do that.
Right.
And so it's a matter of leveraging technology and scale and size and making things wearable. And again, making it non-invasive so you can do things from on top of the skin, just monitoring the skin. Right now, blood pressure, you have a cuff and it has to get inflated and all, it can't be that kind of thing. So that's where the challenge is. So there's still some significant challenges from a technology perspective.
Right, but you also have probably the most tech-savvy generation ever.
That's right. That's
So,
right.
I mean, you have, I'm convinced that some of them are coming out of the room texting their moms and dads, I'm on my way. So I can't imagine that it would be too difficult to conceive of a device that would be simple enough for even a child to use.
And that's where building something into the cell phone, an application on an Apple, to give them at least first feedback, like you said, from an electronic medical record, if they just got their lab results done, if they were going to a physician, to be able to see that visually and see it over time, that's very important, longitudinally. Those kind of things will come, and that is low-hanging fruit. But to make a preventive, non-invasive, real-time kind of feedback, that's where the real challenge will be. One question is in the breath. If you can do something by determining, different metabolic activities from the breath, if you can build that into a cell phone, then like you have it. Everybody's talking on a cell phone doing those things, and if you can determine it. So there's areas that people are looking at, researchers are happening at academic institutions and others, but it is something it's a challenge.
And Jay, from a biological perspective, would that make sense? Would it
Oh,
be
absolutely.
possible?
The more things we can find to detect early, hopefully can motivate people. Let me tell you about two research projects that seem to be impacting on this. In fact, the entire August issue of the International Journal of Obesity, which will be online on Monday, is devoted to an NIH project called Healthy, which this project was really undertaken to see, can we lessen the risk factors for type 2 diabetes in school children. And what they did is they took 42 schools in different parts of the United States, paired schools, so there are 21 sets of pairs, and went in the 6th grade and set up a whole they randomized the schools. So school A would get the intervention, school B would just get assessments. And these were programs designed to change the 6th and 7th graders' approach toward eating, toward physical activity, and toward understanding health issues. And the study's been going on for a few years. It's just about to close. They're doing the last assessments. And the papers describing everything they've been doing are all in this issue. The results won't be known until the end of the year or beginning of next year. But I think it's a fascinating kind of approach. It says, let's go to the middle school where people are really potentially pliable and see if we can get them inculcated into a real healthy lifestyle kind of approach. And they did a pilot program which showed that it looked like it was feasible to implement these things. Now they're going to see whether or not they actually have results by doing it in a large-scale kind of way. If it does, I think it's the forerunner for how we ought to be changing our approach in the schools to all children growing up. So we get back to the President's Program of Physical Fitness that we grew up with, and different kinds of eating patterns. And so it actually could be a very important set of observations. The second study is another interesting one because it relates to some of the things that Mike was saying about how do you assess. Pat Saab, who is an investigator in Miami for the last 18 or 19 years, has had a program where she goes into the 10th grade and takes everybody's blood pressure just to see what it is. And if you relate it to age, the people who are in the 95th to 100th percentile, the highest 5% of kids for blood pressure, she invites to come in and have other testing because they're identified as being a group that's at risk. And she says to them, bring your best friend with you for the evaluation. The best friends really serve as controls, and you got a 95% chance that the best friend doesn't fall into the high risk 95th percentile and above. And they come into the lab. It turns out that when you compare those two groups, The group that had the higher blood pressure also has higher triglycerides, one of the fats. Cholesterol actually didn't change, but triglycerides did. Higher insulin levels, higher glucose levels, and they do an echocardiogram and find there's already left ventricular hypertrophy, increased thickness of the cardiac wall. And it all can be detected with a simple blood pressure screen of all things when you then evaluate them further. What she's now doing is taking those groups, both the control group and the group that was identified, and putting them through an exercise program where they come into the exercise facility 3 times a week and are able to participate to see whether or not that can alter the factors. So I think there are things going on that show that there's a tremendous overlap of these various risk factors, and that there are people really trying to see if we can address them in school-age kids to make a difference. And one of the other things that just came out yesterday, I don't know if you happened to see it yet, in Morbidity and Mortality Weekly Reports, is you were mentioning in your opening that between 2 and 5-year-olds, there was an increase from 5 to 12% of obesity up until from the 80s till 2001. From 2001 till the present, it's been flat. So actually, that's stabilized, thank goodness, and is not increasing further. And so I think there are some good things that we're seeing coming about too.
But it's not going down.
Not going down yet, no.
Not yet.
But
The question is why? What
Yeah.
has changed since that point where it's in fact been able to stabilize? I did read that as well. It's very intriguing.
I think it's very exciting that they need to dig deeper to try to understand what the why is. But I'm glad to see that there's at least some stabilization, because all of the indicators we've been getting previously have just been horrible. Everything's been just increasing dramatically.
Well, it might be there's some good news that the things that we have been doing, which is raise questions about why there are candy machines and soda machines in schools, and addressing some of these issues might be having some kind of impact. And, with respect to that, I'd like to raise this issue of labeling, nutrition labeling, and particularly in restaurants. Because in New York now, where I'm from, restaurants are required to put up their calorie counts for menu items. Pretty sobering when you walk into a Starbucks. So, and I have to say, my colleagues have told me that makes you think
It's not going to
twice.
make me give up my venti non-fat latte.
But it does make you think twice about that Java Frappuccino, which is one of my favorites. So, but again, this is one of those things where if you think about the rising generation, kids coming up, and if they are raised on a system and a culture in which this is part of their everyday life, and they're able to see what they're eating and get a better sense and a better understanding of what they're eating, do you think this is going to make a difference?
Oh, absolutely. Particularly if we couple it with teaching them in the schools to look for the labeling and what it means and why it's important. So I think it's a crucial kind of issue.
I think we have to that end. You have to make it simple. It has to be straightforward. So what calorie count is bad? How much you hear about trans fats? All those things. The high fructose corn sugar, and so if you can really simplify and make it straightforward, because I think that will also, because there's, we talked a lot about McDonald's and but the fast food, there are ways and even meals that they have there that aren't all bad. And so if people start asking for those things or looking for them or avoiding the high calorie count Starbucks and taking the ones tea or things that are less calorie count,
Right.
that's what the people start moving toward. And so if that understanding, I think, is very vital, so the person takes more control. And if they have that understanding through the education, especially the kids in the school system, and we can use, things on the internet, things with cell phones that, give them that kind of information in a real-time fashion, I think it'll make a big difference.
And there is an app for that. There is an app on the iPhone for that. But that's a low-tech thing. So, we're talking about some of the low-hanging fruit that doesn't require all of this billions of dollars of investment to change.
But it requires a change of mindset.
Right,
So
which
people,
might be hard
So
in some
people
cases.
have to really get into that this is important, and that it is important for them and for their families and for everyone around.
That's right, and it's low-tech changes are wonderful if it can help the lifestyle, and those kinds of changes and really understanding how you can disseminate those in different ways. And so when you think about, the classic one that we often talk about is when you look at China, the dissemination of telephone technology was not with wired landlines. They did it through cell phones. So actually, a newer technology way was actually helping them disseminate things in a different fashion. Telemedicine is another one that we're looking at in China or in parts of the world that don't have as many medical professionals as you might have in denser populated areas. And can you use that same kind of that leap instead of saying taking the same equipment or products and putting it in the hands of somebody they don't have as many medical professionals? Can you make simpler products? And actually, simpler products are oftentimes have more technology embedded in them to make them easier to use. So instead of relying on a user to interpret the image, the machine does it itself and just provides a number to the user because they're not a medical professional who's been trained to interpret the image, and then use telemedicine to translate that, relay that back. If it's a red indication, it's in a bad indication, to then send it back to a medical professional, could be somewhere else. So that's where technology can play, and actually when you think about something that's simple, low tech in a cell phone, but oftentimes the technology behind it makes it easier to use, is higher tech.
And you raise an interesting point, which is now let's step outside of the United States for a bit. We're hearing about the trend in diabetes going worldwide. China, India, both have rising rates of diabetes, particularly among children. Do you anticipate that we will see the same pattern of disease occurring there as we did here, or will we be able to apply some of the lessons we've learned here, some of the new strategies, perhaps new technologies, and help those countries not to see the disease trends that we've seen here?
Well, so far it would be nice if we had the technologies and proof that we could
But we are flattening out.
We're flattening out on a couple of things, but it's actually been a worldwide phenomenon. We're not the leader in the world in the frequency of this, and the big problem at the moment is in the Middle East, where the frequency of diabetes is just rising astronomically compared to where it was, and there are other parts of the world. India and China now have so much more diabetes, and even type 1 diabetes, which is my particular interest. It's not the obesity-related one, but it was always said this is a disease of Europoid Caucasians, and you don't see it in the Far East. When I went to China, they said, "Oh yes, we have low incidence rate, but when you take it out over 1 billion people, we have more people with type 1 than you do." Because even though the low incidence then is magnified because of the huge population. And so the problems are really enormous everywhere in the world for both types of disease.
I think that's the big thing that we learn as we go. The patient population is just so large compared to what you might have in the United States, at least. And so one of the things, though, is as Western lifestyle, so to speak, some of those fast food places are coming into those areas. And then also they get more sedentary. It's the combination of the genetic factors plus the environment that you have to really look at. So I don't know if the disease prevalence will change in the same fashion or the same rate, but the underlying causes will be the same.
And unless we address those, as we said, with both diet and exercise, that trend is not going to change, right?
We know the story.
Yeah.
We know the outcome.
Yeah.
And I'd like to address exercise for a minute here, because we're always telling our young kids to exercise more, get more physically active. We know that this is a generation that's sitting a lot more than previous generations have. And yet, just to be provocative, there have been some interesting preliminary, I'll admit, studies out there questioning how much exercise can do. We're looking at this balance of, if we have limited resources, exercise, nutrition, if we have to sort of, put our eggs into a basket. We're not going to choose one or over the other, but a lot of times we have to sort of decide, are we going to put more of our efforts toward nutrition education, or are we going to fund more physical education programs in schools? Some interesting studies coming out suggesting that perhaps exercise isn't as impactful when we look at what it can do for weight loss and for reversing disease trends. How much can it actually do?
It's a complex question. There was just a recent study that you shared with Mike and I earlier in the week, where it was shown that exercise really didn't have a big impact on weight, but it did reduce waist circumference. And what happens is, and that people don't necessarily realize, when you start to exercise, you're going to build up your muscle. Muscle is denser than fat. So the same weight takes up less room. And what you want to be doing is converting your fat tissue to muscle, which is accomplished there, and the evidence for it is the reduced weight circumference, even though when you get on the scales, you don't see a change. And I think that can be crucial, because getting rid of the fat tissue is much more important than what the absolute weight is. And it points out one of the great defects that we have, and maybe GE will come up with a really simple way of assessing the proportion of fat tissue versus weight, so that we can look at this. Because when we talk about what the criteria are for obesity, we're using body mass index, which is basically weight related to height. But you apply that to an NFL football player, it's all muscle, and those guys may have real high BMIs, but when they come into the lab, they are quite insulin sensitive. They don't have any of that insulin resistance, because we've looked at a few of them, and it really is quite a different kettle of fish. And so building up muscle is good, and even though you may have a lot of it, and so I think it's not a simple question that one can get to. And if you're asking where we should put our emphasis, should it be on nutrition or exercise, I think that's the question of which of my children am I going to give up. It's the Sophie choice issue, and I don't want to get into that problem whatsoever.
But there are technologies. There's actually a product that we have demonstrating here to look at what we call body composition. So it looks like a scale when you grip it with both your hands as well as your bare feet, and it does use some impedance work to actually understand what's your bone mass versus your muscle mass versus your fat mass.
So you've already done what I asked
there
you.
You go.
Quick.
You ask, he delivers.
Right. Right on that. It's hard.
So so what we're starting to talk more about is body composition. And to the end, everyone has a scale in their bathroom. They go start either whether it be dieting or exercising, and they get on the scale, and that feedback is very negative to them because they don't see their weight going down. They say, forget it. It's not working for me. It's just not there. I'll wait till there's some pill to take care of it. Well, it's really body composition, which is important. So there is technologies there that is very vital that we're looking at. And beyond that, the next step beyond that is really understand visceral fat versus fat that's built on the fat that's on your abdomen at the layer of your skin is bad, but it's better than fat that's built up around your organs.
So you're anticipating, that's a pretty
that's what you wanna
sophisticated,
see.
that's a pretty sophisticated difference there, analysis that's going to be required at the molecular level. You're anticipating that technology will get to the point to distinguish between is there fat built up around your organs, which is highly dangerous, versus fat that's in your skin composition. So this other nifty device, we'll call it the J device, the J scale. Available yet? The J scale is available, and it's actually as we are going around talking to researchers about it, we're doing that at this point to make sure that it gives the right indication and how you build it into training programs. So we're going to training departments, athletic departments, because they're the ones that are actually in the leading edge, because they understand the BMI is not enough. And so we think that's something that can be adopted in a more general fashion. It'll be a very important technology. Okay. All right. So I think we're now going to bring all of you in here, have some Q&A, and get some more discussion going. Anyone have a question? Do we have a microphone?
We don't even have a microphone.
I guess we don't. So we'll just yell. We'll just talk really loudly. All right. Blue shirt over there.
I just want to make a comment. Mike referenced the device, the body composition. It is demonstrated here. I'll give you a little bit commercially. You can go and have that study done for yourself. It takes 30 seconds, and you get a full printout of your body composition.
Where is it demonstrated? Okay.
Great.
So please take a look at that.
It's next to the registration table.
Right.
Cool.
It's here. You can go have your study. 30 seconds. So please do.
Thank you. Gentlemen.
Seems to me, my lifetime, the most important public health initiative was started by Surgeon General Group on anti-smoking. And that should be the model, because it was about habits and change and huge resources. And it's only beginning, I believe, to be in the public consciousness through lots of forums. But it seems to me that we don't have the funding from the tobacco litigation, but the funding for a massive campaign, it seems to me to be a goal to follow the anti-smoking campaign.
You raise an excellent point. And actually, Everett Koop did a nice job when he was Surgeon General, but it was Luther Terry who was the first Surgeon General to issue a tobacco report in 1964. And in 1964, when that report was issued, 52% of adult Americans were smokers, of cigarettes. That's dropped to 13% now. As you point out, it has been a highly successful campaign, but it has taken 45 years for a whole generation for us to really see the big impact of that. And so I think that we need to have a perspective that's going to involve time as well. We're not going to change some of these things overnight, and I think that's important. But tobacco is a great example of a campaign, and it was really done with lots of education, putting labeling on cigarette packages, changing the way we talked about it in schools, banning advertising in certain types of media, and it was quite effective. I think we can do the same kinds of things with slight modifications, with things that might help our health today that are adverse. And I think the trans fat effort in New York is an example of the beginnings of that.
Yes, I think your hand was up next.
Jay, I have a question. We talked about genetic propensity and we talked about lifestyle. We don't talk about microbial influence on obesity and these other conditions, which at least the literature I've seen is now becoming more to like both bacteria and viruses. Do you have any comments about that?
Yeah, Steve, it's an interesting question, and there have been a lot of correlations that have been done. Particularly, there's a group at Wash University in St. Louis that have been really looking at our gut microbial flora and how they relate to obesity. The issue that still isn't resolved is whether it's cause or effect, whether obese people develop a different flora because they are obese, or whether the flora cause them to have a greater propensity to obesity. And so I'm agnostic at the moment on which way it is. I think it's an area of intense investigation at the moment, and it may lead to different strategies for trying to control obesity if, in fact, we can find some microbes that might be susceptible to particular unique drugs that were responsible for cause. That could also give us an avenue to approach the disease in terms of therapeutics. But I think we're too early in the course of understanding that to make any firm statements.
You say there's a possibility it could be contagious, transmissible?
That's not been brought up. It's that we all do. Most of the cells in our body are not our own. They're our microbes that live within us. And they're generally not transmissible microbes. We get them from our environment, from food and so forth, but not from. I can't give it to you easily, so that's generally not with most of these microbes. We do know infectious ones, for example, salmonellas and so forth, that can cause problems. But most of our gut microbes are benign friends of ours that just live with us.
All right. This side of the room, gentlemen, in the blue shirt.
I would appreciate your views on this. It seems to me that a major root cause of obesity in kids is the lack of exercise. I remember back a generation, in any neighborhood, kids were out from dawn to dusk, very active. And now you drive through most suburban neighborhoods and they're like ghost towns. I asked my daughter-in-law about this. I said, why do you only let your kids do supervised things? She had several reasons, but the fact is that moms now don't let their kids out of their sight. They don't let them play in the neighborhoods. So that natural activity of children just doesn't happen. And I think that's a very important part of this. It's a big cultural change. It's been quiet, but it's really different.
And it certainly can't help that a lot of the physical education programs in schools are getting cut as well. It's one of the first things to go usually when budgets are cut.
Yeah, it's play after school. It's physical education. It's all the things. Whether it's TV attracting it or mothers being overly protective given concerns about things. We just need to really, as a society, say this is so important that we can't not do it.
Yeah, even small things, walking to school, riding your bike to school, you just don't see it. And walking is a great exercise, actually. So if the kids had to walk the half mile to school every day, it'd be better than, they get on the bus and they go.
Yes.
Well, I have a comment. It's not really a knowledge gap. Medicine knows, we know what these risk factors are. It's more of an issue of motivation. Social sciences, doctors talk to their patients and don't get through very effectively. gives feedback that helps people understand the consequences of their behaviors. I think that's terrific. You know, but medicine hasn't got the job done. I think there's a whole marketing element that needs to be emphasized.
And what do you think that block is? You know, why aren't people getting the message?
They get the message, it's just really hard to do. So it's behavioral sciences.
Okay. Motivation, in other words. All right, let's go to the back there.
So as a physician, I talk to my patients often until I'm blue in the face. And I think a lot of patients are, in fact, very motivated to make changes. But I think we have a really uncomfortable relationship between personal responsibility and sort of the structure of different things in the society. And so it's often trying to use technological fixes that are trying to help solve a problem that may or may not be brought on by the technology itself and by some of the structure of our society in terms of parents working longer hours, not able to supervise their children, or perhaps the corn subsidies. And wondering if you could talk a little bit about some of the policy fixes that you could see that might help change the flow of this epidemic.
Well, you bring up some interesting points. The Aspen Institute is in the process of developing a global nutrition task force that's going to try to bring all the stakeholders together to try to think about that. Those would be policy people on the one hand. They would be corporations that are involved in food and activity on the other, academics, and people involved in communication so that we can get the message out in response to the first person's thing, and try to figure out how a concerted effort of getting all the stakeholders in the room and trying to figure out where to put the efforts ought to be to try to help change society. I don't know what the answer is, but I do think bringing everybody together will help. I mean, I was concerned yesterday and raised it during the panel that Mike was on, that a lot of people were making McDonald's the villain. In fact, in many neighborhoods, that's all people can afford to go to. What we need to be doing is working with McDonald's to help, make their choices a little bit better, perhaps. Maybe making the buns a little bit smaller, and maybe more whole wheat, making more of the meat there and less of the French fries, or change the oils in the French fry. There are things we can do within the system that may help get people to be more nutritious, and trying to promote more activity too. I don't know all the answers, but I think that getting the stakeholders all together is going to be a crucial thing that can really perhaps get some bright ideas out of it.
Yes, we'll go to this side of the room here.
Me?
Yes.
So, still, what percentage of diet and exercise can prevent obesity? So if it's 50%, you were doing a good diet and exercise, it's 75%?
I think 100% of type 2 can be prevented with good
And that's been
exercise.
shown in studies.
100%.
People who
So what is wrong with our message? I mean, you have
In studies, it's
$3
only gotten to
billion
58, but the
to
studies haven't gone long
It's
enough.
been
You
reversed.
could be working on some prevention programs or some programs for GE that make you famous, going into communities and saying, instead of you guys waiting to take insulin or doing this, let's see if we can do 100% prevention. I mean, even take a couple of communities and do it and use them. Time Magazine can cover it and follow it. And use it as, I think you talked about it last night, about Grand Junction. That you've got some great opportunities here. Besides just changing, you're not gonna change McDonald's, they make money. I mean, how are you gonna change them? They want people to be that fat, so they want you to eat more of that.
I don't believe that's true. I believe that that they're trying to provide, to meet a demand that people have for needing rapid access to food. And if we can help work with them to figure out how to make it so that it is more nutritious, I think that they'll do well. In fact, if they reduce the size of their hamburger patties so that the total caloric load was reduced, they actually will probably make more profit because they'll sell it at the same price and they have less ingredients going into it. So it may actually be beneficial for them to work with us to try to do things better. From a purely profit motive in that case, I would not make them the villain. I think that's unfortunate.
Every fast food company in the world setting out their patty and saying, here, look how big mine is and look how little yours is for the same price. You're going to have a problem because you don't have to just...
But that's why you have to get.
McDonald's.
That's why you have to get everybody at the
Yes, we
table.
have to get
It's not just McDonald's; it's
Arby's
everybody.
and everybody else.
yes. Yes.
Well, first I wanted to defend the honor of women by saying that fathers also are overprotective of their kids. But I want to pick up on something that was discussed in the very first talk last night, and it relates to this discussion around some of the kind of environmental issues. We've not spent a lot of time talking about the rhythm of life for people who are in the lower end of the income scale. But in fact, especially with the decline, the effective decline of those wages, there is not a lot of time for food preparation when you get home. You're working 1, 2 jobs, you're exhausted, you don't have somebody else cleaning your house. And the real attraction of a lot of these very processed foods is that they're fast. You can throw them in a microwave, and it takes no effort. And if you're a latchkey kid, and I'm not speaking out of personal experience, what you're going to do is you're going to throw something that's easy. So to what extent can we think about technology as a way to make it possible to have better foods packaged in ways that make them easier to use? It's beyond just whether the supermarket carries it, it's whether or not once you get it, you can use it efficiently and you'll want to, whether it's McDonald's offering different kinds of things, or it's some kind of packaging technique in the supermarkets. I think all of us probably ate more salads once they started having the pre-washed sliced salad fixings at the supermarket where you grab and go.
Well, you're starting to see a lot of these technologies, the steamers with all these fancy little, cups within cups and things that you stick in the microwave that don't use some of the heavy
Right.
fats because, so are we going to be able to see more of these? Is that too cost prohibitive?
No, actually, it's very interesting to talk about that. There was a study done. If you look at that grab-and-go salad, that's the fastest-growing thing in grocery stores right now, you pay $6 a pound or whatever it is for that. If you look at the ingredients, it's like $1.50. So they're actually making, to your point, by making it easier, making it in that fashion, people are willing to pay for that because time is such a value. So if you can do a similar kind of thing in food preparation in a broader sense, yes, we talked about Stouffer's and we talked about mac and cheese and all those things, but that is part of what can happen and needs to happen. There's a lot of science that goes into food and nutrition. Campbell's is working on things that reduce sodium, in the soups, in the traditional soups to make sure it's still there. So, food companies are looking at this. I think it'll go with, and some of it is being induced because of labeling requirements. So just like you're saying in New York or what the Surgeon General did, no trans fats. A lot of companies now market that their product doesn't have trans fats. So it is something where the marketing and the consumption rates is starting to drive it. The question is, how can we accelerate it? Is there ways that we can do, and that does bring people together. There's policy things that can be done to just accelerate things, because there's just some, everybody knows trans fat is bad. Just ban it. Can you do those kind of things, and that will help accelerate it.
Yes, over here.
The thing I didn't hear last night, but I just for the first time heard the word this morning, is the word profit. And I was struck by David Kessler's recent book and really turned my thinking around to look at how motivated we all are by profit. I mean, we look at the economic collapse we're going through now. It's profit. I look at some of my behaviors that I'm not proud of that had to do with building profits. And so it seems to me between regulation and getting over a naive, what for me sometimes is a naive attitude that we're here to do good. I just would like to hear y'all's remarks about how much pure, unadulterated profit drives some of the bad behaviors that lead to these outcomes.
Well, I'd like to, as I said, like to see the profit motive be channeled into healthy activities. And I think you can maintain the profit for folks and still make the choices more healthy. Because profit will motivate not only companies but individuals. And all of us probably in our 401ks or otherwise are invested in these companies, and we want to see them make a profit.
Mike,
So
is that realistic, or is Jay just...
No, profitability it's actually a very complex thing. Yes, businesses want to make profit. They're for-profit enterprises, but the fundamental reason for that is because they feel they have an obligation and responsibility to shareholders. And those shareholders are individuals like us in your 401ks or if you have individual stocks. So that's a big piece of it. But profits also build reinvestment in science and technology and sustainability. So if you have a company which is not profitable, it's not going to be around for a long period of time without bailouts. And so that's why it's not an either or. It's a matter of and they will be motivated by what it is, how their products are being consumed. So if you're making a high fat, high trans fat product and it's not getting consumed, you will switch and do something else because you're motivated by.
So it's a
return on
two-way
profit.
street. It has to come from the consumer as well, demanding
That's right.
that we don't want those products
That's
anymore. Yes, right here.
So it strikes me that there's a parallel between the drug interdiction problem.
Okay.
Is it the demand for drugs is the reason the drug problem has been so complicated, and everything seems to be focused on the drug dealers. Well, is it the food dealers? Is it the alcohol dealers? Is it the tobacco sellers? And until you change the demand at a grassroots, at the home level, I was asked to speak on diabetic retinopathy to the dietitian council in Memphis. I walked in the room and I was looking, before I went out to kind of look at the audience. There were 100 dietitians, most of them young women. The average woman, I would guess, in the room was 60 to 70 pounds overweight. And so I said, well, it's my one shot. I'll never get invited back if I make this statement, but I'll say it. So I went up and I said, how many of you believe in leadership? They all raised their hand. How many of you believe that a pro athlete that abuses a woman is a good leader? Nobody. Well, how many believe that if you're a dietitian, doctor, minister, priest, coach, father?
Alice's original point, we have the opportunity for the current generation either to live shorter lives than their predecessors for the first time, or to be a healthy generation and say we're gonna use what they have done wrong to teach us what to do right. And I think it's a matter of just reframing it.
If they take smashed up cars and bring them to the schools to say, here's why it shouldn't be DUI, why don't we have pictures of 300-pounders with 14 IVs running in them in the coronary care unit?
Maybe that's part of the campaign that needs to develop.
Gentleman in the back there.
Well, the last 2 or 3 comments prompt me to sort of suggest 2 major marketing engines that are out there. The one directed towards schools is Scholastic, which is in every child's backpack from the time they're in kindergarten till the time they're in middle school. They communicate, they're in the schools, they talk to teachers, and they affect how children and parents think about major issues. And they've taken on major issues. Now they're in the process of taking on the environment and global warming. I don't think they've taken on this issue, really, and it's a huge opportunity. The second, in terms of providers of major marketing engine, which is generating profit, is Walmart. And Walmart is, the largest supermarket chain in the world. And they almost single-handedly turned the United States from being a consumer of incandescent bulbs to a consumer of fluorescent bulbs by saying that's what we're going to do. So, and they actually probably service or market or people buy who are in the particular target groups. They're especially at risk. So, and they might well be receptive to making a major effort along this line.
Yeah, that's an interesting comment because by making only those bulbs available at Walmart, they've changed, as you say, the way many people behave. What if Coca-Cola would only make available Coke Zero and Diet Coke and stop making available regular Coke?
Exactly.
Would people stop drinking? I don't think so, but maybe they would have something that is going to be less wasted calories that they're consuming. So I think there are things that can be done and not jeopardize. I mean, we still need to have light bulbs, and they're selling different ones, and people are still going to drink various fluids, and maybe it just needs to be different.
Well, to that, I just want to share a very quick anecdote there. We heard about the Cleveland Clinic last night, and I actually visited the hospital. What they did was they took out their fryers from their cafeterias. I don't know if any of you have been in a hospital cafeteria, but it is one of probably the worst eating establishments you can go to in this country now. They took out their fryers, but they didn't tell anyone. So they replaced them with baked potato fries. No one noticed. There wasn't a hue or cry. No one noticed.
Very interesting.
So,
Very interesting.
let's go over here.
So I'm lucky and fortunate that in the younger generation, like you were saying, Ross, that we have so much information and sports and an iPhone, and because I'm Dutch, I download free apps, and I've got Map My Ride and Lose It, and haven't really been part of the whole nutrition side of it, but I'm learning just by playing around with it. And I'm a little bit of a geek in the like longitudinal data, like tracking and monitoring my exercise and what I consume. And how do you? And I see there's a difference. It really makes a difference to be that educated about yourself and talking about prevention and all these chronic diseases. You really can prevent these diseases. So if we can empower people to actually take on that responsibility, how do we incentivize them? We were talking about it earlier. It might have something to do with cash, money. Wouldn't the government, wouldn't insurance companies, wouldn't the nation be able to reduce these costs by incentivizing our population with money to monitor themselves in terms of exercise and food?
Well, that's happening with at the corporate level at the moment. There are companies, I think Target's one of them. I don't know if Walmart is, but there are some large corporations that employ millions of people who are incentivizing their employees to get physicals. I think you can get anywhere from $25 to $100 just for getting a physical or filling out an online questionnaire about your health status, because money talks.
Yeah, Safeway, other companies are doing that. We're looking at doing that at G is to incentivize through, in terms of what the total outlay for benefits and things from an insurance perspective, to make much more of it upfront preventative, controlled by the employee. So if they do these things, if they join the fitness club, if they have some activities there, that there's incentives that are there, that their copay that they might have could be much lower than somebody who doesn't. So there's those kinds of efforts that are going on across corporate America to really look at that, in the sense of earlier prevention, the individual owning more of the responsibility and tracking and those things of what they're doing is so vitally important.
Humana had an experimental program, I don't know what the status of it is, a couple of years ago, where what they would do is if you were overweight and wanted to lose weight, you'd go in and you get all your baseline things studied and sign up. And your target weight would be to have a BMI of 25 or less. From the time you enrolled, you could keep all your receipts, be it hiring a physical trainer, going to a dietitian, buying a treadmill, whatever it was. You kept all your receipts. If you got to your ideal body weight of 25, you turned in all your receipts, they paid 100%. If you didn't get to 25, they paid nothing.
How much time do they give you?
As long as you wanted. I don't know the status of whether they were offering it to a few of the companies that might buy into things. It seemed like an interesting idea to try to motivate people that, if you're going to do it and you're going to succeed, we're going to be behind you.
Important message. All right, I think we have time for one more question. That's right there. Yes.
I work with the World Health Organization in Geneva, so I'm finding this discussion very interesting, but of course it's focusing on one country. And as you said, the problem is across the globe. And I hope that we will be able to work at country level in ways that will reinforce the efforts of other countries. But my main comment is on how do we find ourselves in this situation? How do epidemics sort of like fall on us as if we couldn't have predicted them? Wasn't this type of epidemic predictable? What are the missed opportunities that we missed to be able to predict this? And then, of course, how are we watching out for future generations so that they too don't have these epidemics landed on them as if we couldn't predict them? I'm trying to see a sense of responsibility that looks beyond the problem we have now to the problem that our great-grandchildren will have and their great-grandchildren, because maybe it's for those that we can make a difference. Maybe for the current generation we already let them down. How can we work in
Well, I think you raised a very interesting point, which was discussed yesterday, about this tug between prevention and treatment. And our system is so focused on treatment and on delivering a service when something goes wrong. And our reimbursement structure is set up that way. Our care structure is set up that way. And until we shift that focus toward looking at things that may or may not occur, predicting, looking at risk factors, at things that may or may not occur in our children, that might not change.
But it is there's so many things that come into play because, frankly, the work that's talking about in the green energy area and carbon footprints, that is something that would be an epidemic in future generations if we weren't taking actions now. So there's so many things that go into the environmental factors that affect health and affect what people are doing. So I would use that as an example of the work to become more green as a globe is something that is preventing a future epidemic that would take place. So there are those kinds of things going on, but there are big macro areas that we would still have to look at.
Okay. Well, I want to thank our panelists. And as we heard here this morning, the health of our children is one of our most precious resources, and we're in danger of letting it slip through our fingers. But it's not because we don't have a choice. So we do have options. We do have the opportunity to ensure that our rising generations live better, longer, and healthier lives. So I hope this morning's discussion has stimulated some ideas and inspired you to start thinking about ways to make that happen. Thanks very much. Thank you.